I have nothing to disclose. I think we may actually have finally reached a point where we have a very workable classification that is worth using, and maybe we should sit tight for a little while and quit changing, because we've been changing a lot, and so we'll talk about that. So we'll start a little bit with a case example. So this is a 57-year-old male, small airplane crash, perineal paresthesias, poor rectal tone, incomplete spinal cord injury, and has this fracture pattern. So if we look, we can see he's got what we would probably call a burst, and he's got this fracture posteriorly through the line. So we're going to think about that and keep it in mind, and we'll come back to that as we talk about how we might classify this patient. You can see a little closer up, look at the fracture. You can see the retropulse fragment creating this deficit. You can see he also has a little bit of fracture through one of the facets in the posterior elements. So how do we do this? We can start with just a very simple concept of what is instability. I think we went around the room. That's a very nebulous concept. White and Panjabi basically said that if your spine has the inability to resist axial load and normal physiological function to the point that you have severe pain, functional deficit, or put your neurological structures at risk, that's probably instability. I think we could agree to that. This concept is right, but how you define it and how you quantitate that is really hard. That's where the problem comes. We've had a lot of classifications over the years, and I'm only going to really talk about a couple of these things and how this evolved and how we got to where we are now. Early on, it's very interesting because they had a two-column kind of concept. There was the anterior part of the spine, the vertebral body was resisted axial load, and then a posterior tension band. And I find it very interesting that when we started doing this in the late 60s, 1970, that was the concept, and really that's what we're back to, okay? And that was probably right. And we got into the three-column concept, and how this came about is because we started using CT scans. So early on, these were assessed with tomograms. As CTs came value, it became clear that this middle column was important, this bony retropulsion, and maybe that dictated treatment a little bit differently. And so we came up with the three-column. And then it became clear, and so we divided fractures into four types. Basically a compression fracture, a flexion distraction injury, the translational shear injuries or fracture dislocation, and then burst fractures. And we still use that. I think we all understand that. We all talk in that language. But what became clear is that there were clearly burst fractures. Injury to that middle column did not in itself make something unstable. That became clear. So early on, the concept was 2 columns out of the 3 are broken, that's unstable. Well, that would mean all bursts are unstable. That probably wasn't true. And there were clearly some that had better stability, and so this paper actually tried to sort that out. I don't know that it defined it well. Around that same time frame, we started fixing more burst fractures. And so this classification, the Gaines classification, sought to classify the degree of comminution of the vertebral body. And the reason that came about is because when we started fixing these, and we decided there were burst fractures, 2 columns, that's unstable, we're going to fix these, that was about the same time the fix-it or intern came around. And we could reduce, realign, establish alignment in those fractures, and the x-ray looked beautiful. What we saw, those chance pins were 5mm pins, and they started breaking. And so this classification was to say, okay, maybe this posterior fixation needs to be supported with an anterior graft to resist axial load. And maybe posterior fixation in the ones that were more highly comminuted should also have anterior support or be treated anteriorly. So that's how the Gaines classification came about. I think it's important to understand this also, because conceptually it's still important. Although our posterior instrumentation now is so strong and robust that it is we probably can go back and treat these simply just posteriorly. So that's where that came from. The concept's still important, although it takes on less role. Again, at the same time, the AO, in AO fashion, created a classification based on ABC. And A's were axial loading injuries, B were sort of flexion distractions, and C were the fracture dislocations. And if they had probably left it at that, it would be okay, but then they made sub-classifications, 53 injury patterns. Like it was an A3.12, and like after A, I was always lost. I never understood it. It was just too complex.
Sean, I think it was Jens.
Well, have you heard Jens talk? Sometimes I don't understand what Jens is telling me.
Sometimes. And he does not like this column.
Yeah. So if you look at the classifications, and even if you look at the dense classification, which is relatively simple, there were sub-classifications within that. And you look at the AO classification, what you'll see is the inter-observer reliability is not all that good. It's actually pretty poor. So even when we look at x-rays, it's hard to tell. This study, again, looked at the same thing. They found if you kept with the sort of the most simple forms, the major types of the fractures in either one, you probably could do okay. Like we feel that's compression or a burst. But when you started breaking down into the subtypes for either one, the thing fell apart. And it's the subtypes that really are the problem. The other problem with all these classifications, they were all mechanistic and descriptive, but none of them dealt with neurology. And what we know is that the more severe the fracture, the more the neurology, and it is really in reality the neurology that drives a lot of our treatment. So let's develop another classification. And this really was almost an injury severity score. And they said at this time frame when somebody called you on the phone, they gave you usually the dentist description. They'd say, okay, I have a burst fracture. And then you'd say, well, what's the neurology? It's a conus medullaris injury. And then you would say, okay, what's the status of the posterior ligamentous complex? Because by this point, we had learned that probably what makes a burst fracture unstable versus stable was the status of the posterior ligamentous complex, even though we didn't understand it well. So this paper took those three concepts and tried to put them in a scoring system to guide treatment and help us communicate. And so we got this scoring system, which was great, because suddenly in our classification, we had the PLC and we had neurological status, something that really wasn't clear in other classifications. And this was great. Below 4, it was not on. Above 4 was operative. 4, which was a burst fracture, I'm not quite sure about the posterior ligamentous complex. Never answered the question. You still didn't know. And I would postulate today we still could argue about that. And it may depend on what part of the world you live in. We don't even know how to define the posterior ligamentous complex. And I really like this paper in doing it because you see a lot of edema in the posterior complex. We get these stir images, we don't know what to make of it. And what this paper did is it looked at intraoperative findings correlated with the MRI, and anyone treated non-op with who progressed. And what they found is if you just look at the black stripe for the ligamentum flavum, this one, and the black stripe for the supraspinous ligament, those two things, ignore all the edema in the middle, you just look at those two places, that highly correlates, almost 100% with disruption. So if you see disruption of this line and this line, that's disruption. If you don't, then it's probably not. Pretty good paper. And so the other thing we found is that our old things that we used to guide burst fracture fixation was 50% loss of body height, 30 degrees of kyphosis. Those things do not correlate that well with posterior ligamentous complex disruption and should take a secondary role in assessment. So what about our patient? Okay, so he's a Dennis burst. I think we could all agree he's a burst. If we look at the AO, he's probably a B. It looks like he fractured posteriorly through the spinous process. Some may argue he's an A. If we look at TLEX, if it's a burst, it's a 2, but if we decide it's a distraction injury, it adds 4 points, it's a 6. I think the posterior ligamentous complex, because it's hard to be sure, it's probably a 2, and he has a neurodeficit, so 3. It probably is a moot point, because either way, he's a 7 or 11, and that's surgical. That's above 4. But you can see it can be hard, and if you call me on the phone and say, hey, I got this guy, plane wreck, he's a 7, I don't know what you're talking about. That sounds bad, right? But I don't know what it is. So what happened next is, I think, very important, because the same people that were involved in TLEX were heavily involved in the AO, and people got together and said, well, maybe what we need to do is take the good parts of these classifications, simplify the AO classification, add something about the neurology, and maybe come up with a classification that we can use. So this is the new AO classification. I personally think this is a really good classification. And it took the AO group, or the A group, and they made just 5 types, only 5 types. They said, well, we need to put spinous processes and transverse processes somewhere. That's an A0. So if you only have that, that's an A0. All compression fractures became A1. It didn't matter whether it was a superior end plate or inferior end plate, because historically, we've never treated those any differently. And so all compressions were A1. It separated out this particular fracture pattern, the pincer fracture, which tends to behave badly. It usually is a low lumbar fracture, and it tends to drift into kyphosis, separate it out. And I'll show you an example. Then it took burst fractures and made an A3 or an A4 burst. Both are bursts. One is just the superior end plate, and one involves the superior and inferior end plate, the whole body. And we may treat those differently, potentially. One may require more anterior nods. I don't think it's clear, so they would divide it out. And this is an example of pincer fracture. You can see the coronal split in the body. And what you can imagine, when this injury occurred, this corner buried down into there. So laying the CT scanner, it doesn't look bad. You think, okay, that's lined up pretty good. We can probably treat that non-operatively. It's an A2. So A2 tells you better be very careful if you're treating it non-operative. Initial standing film, not all that bad. But by the 2-week follow-up, it's falling significantly in kyphosis. And although it's only 15 degrees, that's a mid-lumbar fracture. That should be about 20 degrees of lordosis, not kyphosis. So it's really like 35 degrees of kyphosis. So it behaves badly, so it got its own group. They looked at the B group, and they said there's only 3 types of Bs. Bs mean you disrupted the posterior ligamentous complex. And they separated out as B1 this group that is a pure bony chance. The classic chance fracture. These are almost only present in pediatric patients. The reason they separated that one out is because that's the 1B fracture that's probably amenable to non-operative treatment. You can treat that fracture in a brace or cast, reduce it, it will heal, and provide long-term stability. We perched through a lot of those now. The B2 injury was the disruption of the posterior ligamentous complex, the flexion distraction injury. It may have some A injury with it, but it could be disrupted purely ligamentously, partially bone, partially ligament. But this is by far the most common B injury. And then they did a B3 injury, and I would postulate that this is not a good example of one, because they said if the spine, if it's an extension injury, but the posterior stuff's intact, in other words, it just cracked a little in the front, that is also a B injury. This is a really rare injury, because most of these are ankylosed spines, and almost always it's through the back. So this is a very rare injury. This may be the one ankylosed injury that can be treated non-operatively, but it's rare. If you have a B injury that looks like this, with some anterior column injury, you always classify it by the worst injury. So if I have a patient that has posterior disruption, that's a B, so it becomes a B2. If in addition there's vertebral body compression or burst, you add an A number, because that may change what you do. It may change your need for anterior support. So you add the A number secondary and you get an idea. Lastly, so this is the classic B1 injury, bony chance. This injury can be treated non-operatively. Extension in a cast, it heals. You can't even tell this kid had a fracture. This is probably more consistent with a B3 injury, although it does go into the back. It's not translated or displaced. You might be able to treat that non-operatively. And then lastly, they put the C injury. This was all fracture dislocations, rotation, translation. This is the group we call fracture dislocation. If it was a C, it was a C. It doesn't really matter, because our treatment doesn't change much. If you have a C injury with an A component with compression, you would call that a C with maybe an A1 injury. Because if you have a fracture dislocation you're treating posteriorly, you may feel like you need anterior column support or go to the front based on that A component, perhaps. Okay? So then what they did, they said we got to have the neurology. And they made it very simple. N0 means it's intact. N1 meant there was transient deficit at the scene that's resolved. And so when we see a burst fracture come in, it says my legs were tingling at the scene, I didn't feel like I could move it, but they're all better now. We know there was a lot more energy there. There was probably a ding to the cord. We're going to be more aggressive in that circumstance. N2 is pure radicular symptoms, a low burst with an L5 radic. N3, incomplete spinal cord or conus injury or claudic clinus. And N4 is a complete injury. And NX means we know we can't examine it. It's that a pundit patient or the patient who's been intubated at the scene and we have no exam. Then lastly, they put in 2 modifiers. And the modifiers are things that might change our treatment. We all recognize that sometimes it's hard for us to really be sure about the posterior ligamentous complex, and so that gets an M1. So we still recognize that that exists, and we call it an M1. M2 meant there are other things going on that will alter our treatment outside of the fracture pattern itself. Like the ankylosing spondylitis that dictates that. It might be multi-trauma that dictates that, burns. But there's something beyond the fracture itself that is going to alter our treatment. Like we talked last night, there's what we would do ideally and what we have to do based on the circumstances. So you can put that modifier on to indicate that that's the case. Let's go back to our patient. So this is an L1 injury. Start with that. It's a B2, we're going to call it. We could put an M1 modifier on that because we're not sure, but we're going to call that a B2 injury, posterior ligamentous complex. There's an A3, burst with just the superior end plate, the inferior end plate's intact, and N3, which is an incomplete spinal cord injury, in this case a conus injury. And then, in addition, there's an L2 A1 injury. So I would postulate to you, if you closed your eyes and you didn't see that, and you understood that classification, and I told you that's what we had, you could have this picture in your brain. So finally, we could picture that, and I could talk to you when we know both what we're talking about. We could compare B2, A3 injuries. We could look at just N0s, no deficit. We could look at ones that have deficits. So I think we suddenly have something that we can use. I still like the residents that tell me I have a burst with posterior disruption, but really this is something we could use to compare apples to apples, oranges to oranges. So I think thoracic lumbar classifications have evolved very logically to the point we are now. I think this newest AO classification meets the demands. I think we can communicate with our peers. I think we can do comparative studies. I think it is easy to use. It seems hard at first, but it's not that complex. Direct treatment, I think that still needs exploration. And having developed a classification, hopefully will allow us to figure that out. Thank you.
That's nice.